going to enlighten us about the hybrid THR.
Okay, good afternoon everyone. Thank you, Kamal, for your excellent talk regarding uncemented hips. I'm here to talk about hybrid total hip replacement. Thank you, Dr. Mukhopadhyay and Dr. Singh. So I have no conflict of interest regarding this talk. As you can see, National Joint Registry's annual report published last year, the hybrid hip replacements is constantly increasing, and if you see the uncemented use of fixation has plateaued and in fact is slightly coming down. The cemented has come down a long time, and the hybrid is slightly creeping up, and for the last 15 years it's nearly neck to neck now. So I think hybrid fixation is on the rise. If you look at Golden Jubilee, we operate almost 2,000 total hip replacements every year, and most of our surgeons do hybrid. Nearly 50% of us are doing hybrid, some of us are doing uncemented, and the cemented is coming down a long time. So it's basically following the trend which we have seen in National Joint Registry. So what are the advantages of hybrid? Why do we need to do hybrid? It's shown lower rate of revision, particularly as compared to cemented as well as uncemented stems. National Joint Registry has shown that. Kamal just talked about a paper from Pennington and BMJ. It's the most cost-effective type of fixation which we can achieve. And in Finland Joint Registry, it has shown better survival rate as compared to cemented and cementless in older age populations. Recent paper published from New Zealand Joint Registry, published just now in April 2019, showed cumulative incidence of all cause of revision in hybrid fixation as 6.5% as compared to cemented 10.9% and uncemented at 8.9%. So it's a vast difference between the three types of fixation. The poly used was conventional poly here as compared to highly cross-linked poly. Once again, coming back to National Joint Registry, England and Wales, if we look revision rates by age and fixation group, if we have got a patient who's less than 65 years of age, the male patient, the cemented prosthesis survives the best, while in female patient, hybrid survives the best. The patients between 65 to 74 years, hybrid fixation is the best for both genders, while above 75 years of age, cemented prosthesis do the best. The three most common types of hip replacements performed in England and Wales: trident Exeter as a hybrid, Corapinacle as uncemented, and a contemporary Exeter as cemented. If you look at the 13-year and 15-year cumulative revision rate, hybrid is the best among the three. So why do hybrids perform better? I think it gives you best of both worlds. As you can see, most of the revisions with cemented fixation is with the cup. So more than 50% of the cup get loose in a long duration of time and get aseptic loosening. So you can prevent that by doing an uncemented cup. Cemented femoral stems have given long-term results. In fact, 18 to 20 years results have been like 98 to 100% survivorship in not only in tertiary level of centers but in small DGHS as well. Instability is a multifactorial phenomenon which I think hybrid fixation has the capability or the flexibility to change the version, to look at all the independent variables and then change the bearings if needed. Go to a large head, increase your head-neck ratio and the jump distance, and then you can reduce your instability. Early periprostatic fractures, high pain and leg length discrepancy are more commonly associated with uncemented stems, and these can be minimized by using cemented femoral component. If you look at the revision rate for why do THR fails, and the four more common causes are aseptic loosening, the thigh pain or groin pain, dislocation, and periprostatic fracture. So aseptic loosening, as I said before, is mostly due to the cup rather than the stem, which can be minimized by using hybrid. Thigh pain and groin pain can be minimized by using a cemented femoral stem. Dislocation, as I said, is multifactorial, which also can be minimized by using hybrid fixation. And periprostatic fracture, which is mostly associated with uncemented stems, can be minimized by using hybrid. So that's the reason I think hybrid gives you the flexibility and the opportunity to minimize your revision rate. The other indications which include leg length discrepancy, which also can be minimized by using hybrid. If you look at cause of aseptic loosening, Dodd published a paper on what is the radiographic loosening criteria, and especially if you look at, it's a quite technically challenging cementing a cup as compared to a stem. If you look at the first X-ray, the cup is quite open, there is no cement superolaterally, most of the cement is medially, and we know that this cup is going to fail. Looking at the second X-ray, you look at zone 1, there is a radiolucency, and it's been shown that these radiolucencies can progress or can involve wider zones and can give you aseptic loosening or instability and may need to be revised. Uncemented cups, on the other hand, have shown good fixation and has shown increased wear and lysis previously, but now with good locking mechanisms and highly cross-linked poly, I think all these complications are seen less. Femoral aseptic loosening is very rare with Exeter stems. It's quite a common stem which is used by most of the orthopedic surgeons, and the procedure is not as technically demanding and challenging as compared to cementing the cup. Fractures or thigh pain, as I said, periprostatic fractures are more common in uncemented hips. Most of them, these are instigated at the time of procedure and they can be seen in early post-operative period. Most of these fractures are seen within a year and are revised in the early phase, particularly in young patients. There has been studies which show most of these young patients, if they need revision, that is probably because of groin pain, thigh pain, or periprostatic fractures rather than aseptic loosening. As I said, with hybrid we can prevent instability by using large heads. It gives you a flexibility of changing your head from 28 to 32 or even up to 36 millimeter on table. You can change your cup version, you can change anti-version in your femoral stem, you can change the bearings, you can achieve more combined coplanar anti-version by combining your cup as well as femoral anti-version, and a combined horizontal offset can be achieved by increasing your offset ratio to the stem. Leg length discrepancy is another important factors which we need to consider, and I think hybrid reduces that. If you look at cementless hips, shows more leg length discrepancy as compared to cemented hips, and if your leg length discrepancy is more than a centimeter, there have been studies which shows the patients are less satisfied and they want revision. If you do a revision for leg length discrepancy, the chances of your success is less than 50%. This is one of the things which we need to avoid. We discussed about pre-op tabulating in the morning, and I'm just going to show you an X-ray of this patient which we see quite often. a young patient, coxa a Dorian femur, and we all think, okay, this patient is suitable for an uncemented stem. But if you look at the preoperative templating, the right side, I've done the templating with the 50 Exeter stem, and this is an Accolade 2 stem. If you see in the Accolade 2 stems, you are not able to achieve the horizontal offset, which is required to prevent instability. You're going to end up your center of rotation quite laterally, which can cause instability and increase your joint reaction forces and can cause early revision. So I did a hybrid total hip replacement with good horizontal offset and no leg length discrepancy on this patient. So we looked at our outcomes of hybrid total hip replacement performed in Jubilee, and we looked at Oxford hip scores, the satisfaction rate, and the complications rate,
also
along with the
request
revision rates at 1 year. We are still doing this, and we are going to shortly do our 5-year midterm results as well. Looking at 1-year results, we had normal demographics, around 450 patients, 4% of them were morbidly obese, while around more than 40% of the patients were obese.
Also
We had significant improvement in 1 year post-op, Oxford hip score. The 97.7, so nearly 98% of patients were satisfied with their hip replacements. Our complication and revision rates were similar as compared to our published data in NJR. I've just looked at my 500 hips for radiological assessment, and it was done by one of my fellows, so he was not involved in the surgery. Looking at the anti-version for total hip replacements, nearly 500 patients. So the anti-version is around, if you look at initial 100 cases, it was slightly higher with posterior approach, but now it has come down to around 25. Inclination is more or less around 45 degrees for my hips. And this is the combined offset discrepancy as compared to the contralateral side, which is nearly less than a millimeter. So I think with the hybrids, I'm able to achieve a combined offset discrepancy, minimize my combined offset discrepancy. Leg length discrepancy as well, it's less than a couple of millimeters in all my hips now. So I think hybrid gives that advantage of combining your offset and the leg lengths in a proper way. Looking at my complication data, this is for the last 7 years. I had fortunately no instability registered with the Scottish Arthroplasty Project. So I think you can minimize instability as well with hybrid. So to conclude, hybrid address issues of aseptic loosening of cup, which we see in cemented cups. The dislocations can be minimized. Early periprosthetic fractures, the thigh pain and leg length discrepancy can also be reduced using hybrid fixation, which can further reduce your revision rate. Thank you.
These two papers or talks are open for questions. Preferably keep it to questions rather than comments, and if you want to comment, we can do it at the end of the session, please. So any questions? Kamal, the one from me is, you mentioned something about dislocations being less in uncemented versus cemented, did you? No.
No, actually I didn't mention about this.
The long-term survivability of the stem, yeah. So if you look at the longest studies, they are with the cemented hips.
Yeah,
Cemented stems, isn't it?
yeah, the long-term cemented hip studies are there, as you say, but those prostheses are no longer there. So we cannot really apply those long studies. If you look at the uncemented stems, we have actually recent long-term studies, and many of those uncemented hips are still being used.
I come to the one you said. You said revisions are easier with uncemented stems. You said revisions are easier with uncemented.
Yes, yeah, I did say that, and the reason is when you're doing the revision surgery, as you know, you open the femur. Even when you're doing ETO, you still have to pick up each and every part of the cement from the bone. So a lot of it is integrated into the trabeculae. So it takes a long time for them to dissolve or to take out, or you're using Oscar to take out the last cement plug, or sometimes you're pushing your cement restrictor down the canal. So all those difficulties arise while with the uncemented stance, you can just osteotomize around it, and then you're not worried about leaving a piece of it back.
Callum, any experience with the cementants on cement revisions?
I think it's a debatable point, which is easier. I had a question, hip precautions in Glasgow. What do you do? Do you vary?
Basically, we are not following any hip precautions at the moment. We are we are auditing our results. We did a small audit and we looked at what are the hip precautions the patients follow. And unfortunately, patients don't follow any hip precautions. So, out of now 14 surgeons, most of the posterior approach guys are not following hip precautions. 2 surgeons are lateral approach and they are still following hip precautions. We have looked at the first 500 patients. The audit has been started from April, so it's not 6 months. We haven't seen any dislocation. We have reduced our length of stay, we have reduced our occupational therapy input, and if you look at the amount of money we are saving is around £25 per patient.
I'd just like to say in Birmingham we generally don't use hip precautions either. But another point is, whilst because I understand you use spinal anaesthesia, do you use a Charney wedge until the patient is woken up, or you don't use a Charney wedge either?
No. We don't do any hip precautions. The patients are, some of the patients are going on day 1 or so we're not following any.
So do you allow them to squat?
Depends on the patient. You ask them not to squat, but they still squat. I had a patient who came for the second hip.
Yeah, I know. We always have patients who squat. Who come and show you that they can squat.
We don't follow any hip precautions. No hip precautions.
Okay, so you don't say don't squat. Okay.
We don't have that much population who squat there, but sometimes we do get some yoga enthusiasts who adopt all kinds of postures.
Okay, from that, or you allow them to do that?
I do warn them, but they still carry on.
Yeah, okay. Great. Thanks very much. Any other questions? Okay, great. Thank you very much for an excellent session. Yeah, sure.